I'm Kelly McFarland, your facilitator for today's webinar. This webinar was organized by Swords to Plowshares and is designed for the grantees of the California Women Veteran Project and the Swords to Plowshares ReGrant program to gain a cultural understanding of the women veterans they plan to serve through the grant. Women are the fastest growing cohort in the veteran population, and over the next 20 years, women veterans are projected to double in ranks to an estimated 15%. Many women veterans are accessing care from providers in the community. Therefore, it is crucial for community behavioral health providers and advocates to have a cultural understanding of the unique issues and experiences of women veterans. Our guest presenters today are Starlyn Lara and Dr. Courtney Valdez. Participants may type a question at any time to today's speakers or Swords to Plowshares staff. Simply type your questions in the question box on the right side of this webinar's display. At the end of today's presentation, we will review the questions and comments posted. Kevin Miller, one of Swords to Plowshares organizers, will be online during the webinar to provide technical assistance during the presentation. Please note, this webinar is being recorded. Our first presenter, Starlyn Lara, served nearly 12 years on active duty, achieving the rank of Staff Sergeant and deploying around the world to such places as Bosnia and Iraq. Ms. Lara earned her bachelor's degree in Business Management and Organizational Communication from Cal State East Bay. Ms. Lara now serves as the Women Veteran Program Manager and Community Educator for San Francisco-based Veteran Services Organization, Swords to Plowshares.
Good morning, and thank you all for joining us. Combat to Community was developed to educate the public about the unique experiences of veterans, the obstacles to care, and the resources available. In this presentation, we will focus on new approaches for addressing domestic violence and intimate partner violence in the veteran community. Swords to Plowshares has been serving the needs of veterans in the Bay Area since 1974, providing wraparound services in a continuum of care. The Institute for Veteran Policy works to ensure that all veterans have the services and support they need. We work hard to ensure that local, state, and national programs for veterans and their families are appropriate, accessible, and adapt to the community's changing needs. What I hope you learned today, I hope that the first part of today's presentation will give you an overview of the veteran experience with a focus on men and women serving in the current conflicts in Iraq and Afghanistan. This should give you a general idea of the issues and obstacles military veterans and their families face. When you think of a veteran, what do you see? Do you know that the median age for men is 64 years old and it's 49 for women? However, about 40% of the recently separated veterans are under the age of 25. Most young adults spend their years after high school and college. However, men and women of the same age that are serving in the military are fighting the wars in Iraq and Afghanistan. Their life experiences are drastically different. By the time I was 24, I was a combat veteran leading a team of 22 soldiers in the desert of Iraq. What were you doing when you were 24? Women make up 20% of new recruits, 15% of the active duty force, and 22% of the National Guard and Reserves, 10% of the overall veteran population. Women are the most rapidly growing population in the military, and the numbers are expected to double over the next 20 years. I hope that that piece of information is reiterated over and over again, not only through this presentation, but presentations that you may participate in the future. Combat exposure, as well as the military experience, is unique to women that are currently serving in Iraq and Afghanistan and different from those that were serving in generations prior. Many women who are serving in the current conflicts and who have served in the military are not only mothers, but often are part of dual military families, meaning that both partners are either serving in the military or have served. So when you have families with the complex issues of one person serving in the military, there are many families that are experiencing those complicated issues because both parents are serving in the military. With the increased number of women serving, many are single parents who join the military as a way to provide for their families. They became mothers during their military service. Many people often overlook that women serve in combat. They participate in room clearings, searching of civilian women. They are truck drivers, military police, and helicopter pilots. They are exposed to improvised explosive devices, rocket-propelled grenades, and incoming artillery fire. Women often struggle with family responsibilities and with the commitment they've made to serving in the military. There are a few things that set current conflicts in Iraq and Afghanistan apart from previous conflicts. These wars are being fought with an all-volunteer force that in fact make up less than 1% of the population that has ever served in the military. All branches of the military have played a role fighting the war on terror. Many service members have multiple deployments under their belt. It is not unheard of for a soldier or a Marine to have been deployed 8 to 10 times. Soldiers, for example, deploy for a minimum of 12 months, which could be 8 years of his or her life spent away from home. Military culture is what makes choosing a career in the military different from all other career fields. The military is not just a job, it's a way of life. It is an institution that is designed to mold young men and women into technically and tactically proficient warfighters. The military is not in the business of making civilians, and for many, what made a person effective in the military could make life after deployment and outside of the military difficult. And that leads us into battlemind. Battlemind are the skills that helped men and women survive in combat, but may cause problems if not adapted when they return home. This part of the training is designed to help veterans and family members understand and deal with the combat experiences. Veterans, we change during deployments. We need to be able to understand these changes and learn how to change again after each deployment and when we leave from the military. Our support systems are the key to a successful transition from deployment. One element of battlemind is emotional control versus anger and detachment. In combat, controlling your emotions is critical for mission success and quickly becomes second nature. However, emotional control involves both holding in and expressing feelings. So at home, failing to display emotions around family and friends will hurt relationships. Veterans may be seen as detached or uncaring. Showing emotions is important for keeping personal relationships healthy. Mission operational security versus secretiveness. In combat, military personnel talk about the mission only with those who need to know. They talk about combat experiences and missions with unit members or those who have been there and done that. At home, they may avoid telling spouses or significant others where they are going or when they will be back. Operational security involves providing information to those who need to know and trusting your fellow soldier. We need to learn that the need to know after your military service and after deployments now includes family and friends. Lethally armed versus locked and loaded. In combat, carrying a weapon at all times is mandatory and as a matter of life or death. At home, a veteran may feel the need to have a weapon on them at all times, believing that loved ones are not safe without them. In the combat zone, they developed and followed strict rules for weapon safety, including when and where to fire their weapon. At home, they have to resist the desire to have a weapon locked and loaded for safety reasons and never use a weapon to threaten or intimidate loved ones. Mission accomplishment versus failure. In combat, they are taught to never give up, win at all costs. At home, it can be very difficult to accept situations that are out of one's control. Inflexible interactions with spouses, children, and friends often lead to conflict. It is important to acknowledge that family members may have developed new ways of doing things in a veteran's absence. In combat, driving unpredictably fast, using rapid lane changes, and keeping other vehicles at a safe distance is designed to avoid improvised explosive devices. However, combat driving is necessary to avoid danger at home. Combat driving may feel right, but it is often very dangerous. At home, aggressive driving straddling the middle lane, often leads to speeding tickets, accidents, and fatalities. Not to mention it can be very scary for spouses and children. In combat, split-second decisions that are lethal in highly ambiguous combat environments are necessary. You have to kill or be killed. That combat anger involves appropriate responses to an actual threat. However, at home, it takes a little bit of time, energy, and effort to understand the real threat and understand the real threat to their safety and their family safety and to react appropriately. In combat, no one understands a veteran's experience except for the battle buddies, those who were there with them. Their life depended on that trust in their unit. However, at home, they may prefer to be with their battle buddies rather than their spouse, family, or friends. A veteran may assume that only those who are there with them in combat understand or even care. They may avoid speaking about their experiences to friends and family. Cohesion in combat units results in bonds that will last a lifetime. But back home, friends and families have changed, and reestablishing these bonds takes time and work. It takes time to develop and renew relationships. To sum it up, battlemind serves as a resiliency tool to help service members change after deployments. They need to be able to understand these changes and learn how to change again. Our support systems are the key to a successful transition from deployment, and we need to learn how to provide support and accept that support from our family. I know that this portion of the presentation and all of the elements of battlemind would have been immensely important and useful when I returned from combat in Iraq and when I was beginning my transition as a civilian when I left the Army. battlemind really does translate across many platforms. It's not only appropriate for dealing with situations of domestic violence and intimate partner violence, but general transition and stress relief and a overall resiliency tool. battlemind is an amazing way that we can educate ourselves about the changes that we have experienced. Service members and veterans are the conduit for families to access care and services. This can make accessing care difficult for those who have experienced domestic violence and intimate personal violence. Caregiver burden can be very difficult, especially in the cases of severe physical injuries, amputations, and paralysis. They left home whole, and some of them have come back broken. Many times, families have this expectation that as soon as a service member returns, that they need an opportunity to celebrate and have a warm and rich welcome home, a nice little party, an opportunity for friends and family members to reconnect. But most of us need a little bit more time to regain our footing and understand our path in the communities outside of our military service. Family members often are the element that either makes that transition successful or not. So some of the major stressors, not only for veterans, but also for their families. Military service and deployments often create stressors that not only impact the service member, but it also impacts the families and their support system. One might say that military spouses and children have the hardest job in the military. During the first half of this presentation, we'll look more into family members and loved ones. Veterans and PTSD. Post-traumatic stress as a result of combat exposure, traumatic brain injury, and military sexual trauma require specialized treatment and understanding. We're not going to spend a whole lot of time on any of these topics. We're going to go over them briefly, and if there's anyone who wants to learn more about any of the major stressors that veterans are experiencing, you can contact me. We have many webinars located on our YouTube site, but this is an ongoing initiative to make presentations and webinars available. So if there's any one element of this presentation, I'm sure that we'll be able to provide you with specific information on that one topic. Rates of post-traumatic stress and Rates of post-traumatic stress and depression are higher for reservists than active duty. Repeated deployments and short dwell time is the time in between deployments, increases the likelihood of an individual developing post-traumatic stress and other mental health-related conditions. Post-traumatic stress is an exposure to a traumatic event. It may be experiencing, witnessing, or being confronted by death or serious injury, and it could be experiencing intense fear, helplessness, or horror. Veterans may not know that they have post-traumatic stress, but their family members will. They may be paranoid and untrusting. They may have severe mood swings where they snap at the smallest thing. They likely have nightmares, flashbacks, and a lack of sleep. Post-traumatic stress does not always develop immediately following a traumatic event. Sometimes there is a delayed onset, and this often happens when they return from deployments. Traumatic brain injury is the signature wound of the current conflicts, and because there are many that may not display signs of physical injury to the head and neck, these injuries are related to and known as the invisible wounds of war. Repeated exposure to improvised explosive devices, mortars, and rocket attacks can cause diminished brain function, where it is difficult for veterans to understand the behaviors, anger, and consequences of their action. Many veterans with traumatic brain injury are also diagnosed with post-traumatic stress. Substance use. The military has a drinking culture. Everything revolves around drinking. You celebrate with drinks. You celebrate punishments with drinks. It's not unheard of for someone who did not drink prior to joining the military to developing quite a knack for enjoying an alcoholic beverage. I stated earlier the veterans may be paranoid and untrusting. They may have severe mood swings. They may have nightmares, flashbacks, and lack of sleep. Drugs and alcohol is often used as a coping mechanism and often used as a way to get and achieve sleep. Military sexual violence and trauma. Service members often wait until they're out of the military to seek treatment for sexual assault. Sexual assault, and this, if you remember one thing from this presentation, sexual assault doesn't only affect women serving in the military, but it also affects a very large number of men. Military sexual trauma most often occurs in a setting where the victim lives and works. This is different from many sexual assaults that occur in the civilian setting, and here are some of the reasons. The victim may have an increased sense of feeling of helplessness, powerlessness, and a risk of additional victimization. The victims may be relying on their perpetrator to provide their basic needs, including medical and psychological care. The career goals of victims are disrupted, either because a perpetrator that's responsible for their career advancement decisions, or because victims choose to end their military career to escape from their perpetrators. In the civilian context, victims, In the civilian context, victims may have reported or ignored, or even worse, they blame themselves for the experience. This type of invading experience is likely to have a significant impact on the victim's post-military experience as well as post-trauma adjustment. Certain aspects of the military culture make it even more potentially destructive than in the civilian world. Domestic violence and incarceration. We talk about all of the elements of battlemind. We look at the increased use of drugs and alcohol and substance use as a coping mechanism. In the military culture as well as the veteran culture, domestic violence is often not related to and connected to incarceration while you're serving in the military. We'll talk a little bit more about the difference in reporting procedures and how what resources and elements that victims of domestic violence, for those who are currently serving in the military and in military families, have access to. Suicides currently are in excess of 22 suicides per day. When I started working at Swords, this number was 18. This number is projected to be 26 by 2015. So 26 suicides per day is an enormous number of suicides. And so when we take into consideration those who have undiagnosed and untreated post-traumatic stress, those who have experienced sexual assault, combat exposure, combat threats, multiple deployments, short dwell time, suicide is and will continue to be an issue that hopefully does not leave our minds, and we ensure to provide education, training, outreach, and services to veterans at risk. I wanted to come back to the slide that we talked about a little bit earlier, just as a way to bring you back and looking at depression, suicide, and major issues, homelessness, violence, jobless, family instability, and that all of these issues are interrelated. Not only are these issues that veterans face, but their family members are also laced into that issue. Domestic violence. Aggression is not only encouraged but highly rewarded in the military, and oftentimes that aggression leads to violence at home. More than half of the veterans who refer to mental health evaluations reported instances of shoving, pushing, and shouting. There's likely a co-occurrence of intimate partner violence with service-related issues. Courtney Valdez will talk about this a little bit more in the second half. I just wanted to make the connection between domestic violence and intimate partner violence in this first half of the presentation. So we're talking about domestic violence. It is impossible not to also talk about the issues and the increased number of reported cases of spouse and child abuse. So since 2008, the numbers have increased. But also since 2008, there has been increased initiative to identify and track some of the numbers of reported cases. Most military installations before 2004 didn't have a strong relationship with identifying and tracking reported cases of spousal abuse and child abuse. Military installations consider domestic violence and child abuse a little bit differently than we value it in the civilian world. Hopefully that will become very clear as we're looking at some of these additional slides. So reporting of domestic violence and child abuse in the military is a little bit different, and one of the things is the military culture that we talked about earlier. So living on base or off base, many families identify with a culture that is a conduit to care. If I am a spouse and I need access to health care and I need to go to the medical center on a military base, the identification number that is on my ID is my spouse's identification number. So there is a strong occurrence between accessing care and services and benefits that is directly correlated to the service member, and there's very little attempt made to ensure that family members' confidentiality is maintained, especially when the conduit to care involves a chain of command. Obstacles to care and reporting. In addition to the numbers of those in our civilian community that we understand do not report instances of domestic violence and child abuse, it can be even more complicated in the military. One of those is due to the Lautenberg Act or the Lautenberg Amendment. This states that if a service member is found guilty of a domestic violence or child abuse crime, that they will not be able to hold and carry a weapon. Not being able to carry a weapon is almost certainly a career ender. So if you were to lose your military career, if you were to be fired from the military, that is a direct connection between the conduit to care for their families. So in a sense, often families consider that the use of the Lautenberg Amendment is a continued punishment for them reporting instances of domestic violence and child abuse in families. We're talking about the instances of a culture on a military base and installation. Economic dependence and the economic dependence on a spouse's and family members, predictable income. As we spoke about earlier, there's a lack of privacy issues and confidentiality. The National Guard and Reserves are a complicated issue because they do not have access to a military base or installation and often don't have access to the same types of care and benefits that the civilian community would think that the National Guard and Reserve have access to. However, the National Guard and Reserves actually have a higher rate of reported cases of domestic violence, only because they do not have to report the cases to the chain of command or through the military installation. So the services and benefits are drastically different for the Guard, Reserves, and the active duty component. In addition to the military's culture in being an institutional barrier to reporting, the Department of Defense characterize child abuse and spousal abuse and intimate partner violence differently than the civilian world. I apologize for coughing. My voice is getting very, very dry. Training influences thoughts and behaviors long after separation from the military. In civilian, excuse me. In the civilian community, what can you do to provide services for veterans and their families who may be experiencing domestic violence? Hopefully, the portion that we talked about with battlemind and understanding that the training that influences thoughts and behaviors may not be the only component that that increases the likelihood of domestic violence in families. But when you think of battlemind and the multiple deployments and the combat-related stressors, thank you. It's often very difficult for service members, veterans, not only to adapt to the changes that they've experienced in the military, but it's often really difficult for family members to also change with those conditions. Civilian organizations do not really understand the network that veterans and service members have access to, especially when there's a lack of services directly connected to domestic violence and child abuse. VAs do not target or provide services for family members, especially in these categories. There are a few veteran-specific organizations, such as the vet centers, that do offer services to families, and I'll talk about that briefly in a couple of following slides. But understanding that organizations in our civilian communities that are offering domestic violence services are likely to be the one element where families can get some help and assistance. Families that seek care and education, counseling, and support often find that they're able to meet their needs and learn through the experiences and find particular treatment options that work best with dealing with post-traumatic stress, the coping mechanisms for traumatic brain injury, and addressing resources with community-based organizations, veteran service organizations, peer support models such as the Wounded Warrior Project, and Vets for Vets. On our website, we have many different resources that range from women veterans fact sheets. We have a domestic violence screening guide. There's literature and resources, as well as facts and figures and a resource and training guide. Legal services for military families are scarce, far and few in between. However, the LA Healthcare is a great resource just for identifying resources in the community that help not only with domestic violence, drug and alcohol and substance abuse resources. Swords to Plowshares pro bono program and all of the resources that pertain to our legal services within Swords can be found on our legal services and pro bono website. There's the military and veterans pro bono panels, so there's also resources within the county bar associations. Military families and veterans families do have access to resources through the civilian community. So supportive services for veterans and their families is a resource that helps with economic instability and potential homelessness among veteran families. Vet centers offer transitional supportive services for combat veterans and those who are experiencing post-traumatic stress. The caregiver support program through the VA has expanded in the last 5 or 6 years. There's a lot of resources available to caregivers that hasn't always been available, and that is particularly useful for family members that their roles have significantly changed due to severe physical injuries or debilitating amputations, paralysis. So California Women Veterans Project and the grantees, which is what is part of this webinar series, you can find information on the strength and assistance of care resources on our website. VA hotlines, Veterans Crisis Center, the Combat Call Center, and the Women Veterans Call Center are resources available not only to veterans but their family members. Veterans are likely to be the last person to pick up the phone and call for help. These resources are tremendously important. They're open 24 hours a day. The Combat Call Center is staffed by all combat veterans. The Veterans Crisis Line is not only receives education and training about veteran service, their cultural competency, about post-traumatic stress, traumatic brain injury, but also resources in your communities that they can make referrals and references to. Thank you. We have some time. We'll take some questions.
Thanks for that informative presentation, Star. We currently don't have any questions, but we did have a couple of relevant comments I think I'd like to share with the attendees. Star, if you wanted to mute your mic there. We did have a couple of comments with regard to the legal portion of the presentation. We have an attendee who's indicating that in her experience or his experience working with the DA's office, the judges are well aware of service members' plight and typically make adjustments on a case-by-case basis. So I wanted to share that that was one of the experiences of one of the attendees. At this time, do we have any other questions or requests of information for Star? Please feel free at any point during this presentation, even if we're moving into our next presenter. If there's something that came up during Stars that you then remembered, please feel free to ask questions about all of the content in today's webinar. Thanks again, Star. At this time, we're going to begin the second half of our webinar focusing on intimate partner violence among women veterans. Dr. Courtney Valdez has been a clinical psychologist at the San Francisco Vet Center since 2010, treating veterans who are struggling with readjustment issues, combat trauma, and or military sexual trauma. Dr. Valdez obtained her PhD in clinical psychology at Arizona State University. She completed her internship at the VA of Northern California Healthcare System and her postdoctoral training at the University of California at San Francisco General Hospital. After completing her training, Courtney obtained a position at the National Center for PTSD at the VA Palo Alto Healthcare System. There she served as faculty through the clinical training program, worked with the Military Sexual Trauma Monitoring Support Team, and has conducted research in the military sexual trauma. Since 2007, she has delivered numerous trainings for providers who work with veterans and their families. Dr. Valdez is a VHA certified provider of cognitive processing therapy and integrative behavioral couples therapy. Welcome, Dr. Valdez.
Thank you. I'm glad to be here. Thanks for the invitation to SWORDS to present on this important topic. I'm just waiting for my presentation to come up, and I'll get started.
Dr. Valdez, we apologize for the delay. We should be showing your presentation shortly.
Thank you.
Dr. Valdez, I believe your presentation has begun. Apologies
Great.
for the delay.
Thank you. I wanted to speak today a little bit about the material for this presentation. There's a recent article in the Journal of Women's Health written by staff members at the VA hospital who talk about women veterans and intimate partner violence and the current state of knowledge and future directions. So I took a lot of my presentation content from this article, but I wanted to just highlight Dr. Gerber and Dr. Iverson in particular, who wrote that article. Today I want to talk a little bit about three areas: intimate partner violence in women veterans in particular, the research and prevalence about this phenomenon, and some clinical considerations for women vets who experience this. I want to speak a little bit about the definition of intimate partner violence. Oftentimes people use the term domestic violence, and the terms are used pretty interchangeably. I use the word intimate partner violence only because I think the latest thing I've heard is that it's certainly not restricted. It's not a restricted phenomenon to something that's domestic. In other words, it's not something that's just occurring in the home, in the sort of traditional sort of family structure, that this is something that happens, you know, in partnered relationships and non-domestic relationships. And so this intimate partner violence means the same thing, but I think the idea is to have it be more inclusive. So the official definition I operate under when I think about this phenomenon is it's a pattern of assaultive and coercive behaviors, which include physical, sexual, psychological attacks, and economic coercion. Adolescents or adults will use this against their intimate partners. So that's where I'm coming from here. Obviously, there are different types of intimate partner violence in general. You know, you can think about sort of the stereotypes of what it looks like, and often what we'll get is this sort of image of a physical violence, right? Hitting, pushing, grabbing, biting, choking, shaking, slapping, that kind of thing. But it certainly includes sexual violence as well. And it includes threats of physical or sexual abuse. So lots of times I want to make sure my patients are aware, or my clients are aware, that when I ask about an experience of intimate partner violence, you know, they may not think that a threat would be included. So, you know, oh no, my partner has never laid a hand on me, but how often does he punch the wall and put holes in it and scream that he wants to kill you? That would count as a threat. That would count as intimate partner violence. So we're not just talking about hands-on contact here. Certainly psychological or emotional abuse is included. Humiliating language, putting down, isolations, threatening. And stalking, I include there as well. People, you know, following you to work, waiting for you after work, harassing you, any sort of unwanted contact that would make you feel afraid by a current or former intimate partner. In the United States, so here's just some broad numbers in the United States, so not specific to veteran populations. What we know lately, or the latest, is that a national survey, I think it was in 2011 was when this was last conducted. So it's pretty representative of the United States as a whole. This is by the CDC. Found that 29% of women and 10% of men report a lifetime experience of rape, physical violence, and or stalking by an intimate partner. The highest percentage of the first time IPV is experienced, so the first time anyone experiences intimate partner violence, that is between age 18 and 24. So we're talking about a pretty young population here when this is first coming on board. And what we know, too, is that the highest rates of intimate partner violence in women is between 18 and 24 and between 25 and 34. So why this is relevant for us today is when we're talking about military women and women in the VA system and just sort of a veteran experience of our women, this is a pretty at-risk age group. So I want to keep that in mind, that this is why it's important that we're talking about this. Gender. So intimate partner violence is not specific to women, and I want to make sure that that's clear. But what we do know is that relative to men, women are more likely to experience injuries as a result of their IPV. They're more likely to fear for their safety as a result of their IPV, and they're more likely to report poor physical and mental health after IPV. So what we're saying here is that intimate partner violence, while may go both ways at similar rates or equivalent rates, that the actual experience of it is usually much more severe, much more serious for women than it is for men, and has longer-lasting deleterious outcomes for women. So now let's talk a little bit specifically about the women veteran population. Star covered some of this in her talk, but basically here's what we know, just briefly. What we know is 15% of active duty military forces are women, and that this has been a really big increase in the last 30 years or so, 20 years ago or so. And that we know that of the total veteran population in 2013, 10% are women. And 6% of our VA population are women. So this is growing, obviously. I'll talk more about that in a couple slides from now. But this is a growing and active population. Something you should know, too, about women veterans is that 1/3 of them, aged 17 to 24, have children. And 39% of women veterans under 65 have children living in the home. So I'm saying this for one reason. I'm including this for more than one reason. It's important to think about sort of, one, the stress level in the home, if this is occurring in a home. And so having children, obviously multiple responsibilities, dealing with readjustment issues, going to school, going to work. All this is happening for our women that in the context of, taking care of a family, being responsible for dependents. And not only that, but if intimate partner violence is going on, obviously there's a chance for children to be at risk, because when there's intimate partner violence in the home, odds are higher for children to also be abused in those kinds of settings. So I want to just make sure that we are not only screening our veterans, but also sort of inquiring about any children in the home, what might be going on there. Again, Star covered a lot of this. Women veterans also report higher combat exposure these days. So especially OEF and OIF vets report, 73% of them report combat exposure. So this is a multiple trauma situation if IPV and combat exposure and other things might be on board. Women veterans report fewer opportunities for peer support. So this is important to think about because what we know from the literature about, for example, PTSD, is that after a traumatic event, not everyone will develop these mental health disorders or diagnoses or whatever. It's not a guarantee. But what we do know is that one of the most significant impacts or factors that predict whether someone gets PTSD after a traumatic experience is the presence or absence of good social support. So if women veterans are already reporting that they're getting more exposure to trauma and have less opportunities for peer support, then what that's telling us is that they're at higher risk for then developing mental health sequelae, so these sort of conditions. And I want to take the time, too, to say that intimate partner violence is not a mental health diagnosis. It's an experience. So, you know, we would be careful about stigmatizing and sort of saying, oh, you know, this, just be careful about that. It's a trauma experience, but it's not a guarantee that then someone necessarily requires intensive mental health care after this experience. Another important thing that I think Star highlighted also is that 48% of military women are married to a fellow service member versus 7% of military men. So why this is important is, while we're not focusing on this topic today, but there's been some research about perpetration rates of intimate partner violence in the military, and veteran populations report higher rates of perpetration of of intimate partner violence. So we know that, again, if our women vets are married to folks who may be, not guaranteed, but may be also struggling with their own issues and may also be at higher risk of perpetrating intimate partner violence, we're just sort of seeing a population that's at high risk. Just a little graph about women vets in VA and men versus men vets in the VA. While, again, I said women veterans make up just 6% of the total VA population, what we know is that the women vets who are using VA services are young. Again, Star said this, I think, too. But when we think about the context of who's at risk for these experiences, it's the women who are being seen at the VA. Overall, more prevalence data, 36% of active duty women report physical, sexual, and or psychological IPV during service time. So we're talking about just in the window of when they were in service, what percentage are willing to say, yes, this happened to me while I was in service. So 36%, I think, is probably a pretty low number. But we do know that that's low, and that it might be an underestimate, not low. It's obviously a high number, but might be an underestimate of the true prevalence. There was a recent study that said, by the CDC, that actually said that active duty women and wives of active duty military have lower rates of intimate partner violence than do non-veterans. So there's a little bit of a conflict here, and I think one way to think about that is, again, the reporting issue. So are active duty and wives of active duty feeling comfortable to tell CDC researchers that, yes, this has been my experience? Maybe we're looking at something that's, you know, reversing a trend, and I would like to think that's true, but it might just be that people are underreporting in this particular study. Other data share that women veterans have higher rates of lifetime intimate partner violence than non-veterans in the same cohort. So basically, if we look at women who are vets and women who are not vets, what we notice is that, in general, veterans report much higher rates, 33% versus 23.8% of a lifetime experience of intimate partner violence than do non-veterans. So more unhappy numbers here. What we're noticing in the VA, so now not every woman vet goes to the VA, but those who do, there have been a few studies to look at the prevalence in our women vets in VA. Unfortunately, we don't have any national data yet on women in VA and their IPV rates, but what we did find in a study, Midwest study of primary care patients, so Midwest VA, found that 74% reported a lifetime history of intimate partner violence, and 24% of women vets under age 50 reported past year physical or sexual intimate partner violence. So again, this is in a primary care setting. This is not in a mental health setting. This is, you know, we're going to go do a survey. We're going to ask these women who are showing up to see their doctor to fill out the survey. And it's shocking to me that we're getting numbers like this in a setting like that. So, you know, there's not just sort of the circle, no, 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 no. But the fact that it's this high suggests that this is a really at-risk population. A New England study sort of echoes this. This is another study done by the VA in New England, found that 29% of women veterans in recent relationships report past year physical, sexual, or severe psychological intimate partner violence. So we're not asking lifetime here, we're just talking in the last year, how many of you have had this happen? And so, again, rates are high. What they also found, which I thought was kind of interesting, is that a greater risk was found for women with a less than college education, and a greater risk was found for women who'd served in the Army versus other branches. So just something to keep in mind. Let's talk a little bit about comorbidities. So co-occurring conditions. So when IPV is present, what else might be contributing or might also be another issue that our population is struggling with? And two main areas I want to highlight are traumatic brain injury and homelessness. So what we know about traumatic brain injury in these kinds of this population is that it's a risk factor for intimate partner violence. And it's also an impact of intimate partner violence. So 11% of our OEF and OIF women veterans screen positive for traumatic brain injury, which puts people at risk for a future IPV. And 30%, and also in this study, women veterans were asked about what happened after their intimate partner violent experiences, and 30% reported a loss of consciousness during their experience, so that suggests a traumatic brain injury, and 67% report residual problems, so whether that's like problems with concentration, for example. Homelessness is another comorbidity. This is a big range. But 30 to 90% of homeless women report experiencing intimate partner violence. So this is not homeless veterans. This is homeless women. We don't have any studies specifically about prevalence in homeless women veterans. But we know that obviously that this is something that happens quite frequently in this population. We know that intimate partner violence is a leading contributor to homelessness. So thinking about this just makes logical sense. You know, if this is occurring in your home, in your domestic situation, and you need to leave, and you have no place to go, this would be a contributor to a homeless experience. We do know that women vets, in general, are 4 times more likely to be homeless than non-veterans. And women veterans age 18, again, this range, age 18 to 29 are at highest risk of homelessness. So I'm not saying anything causal here. I'm not saying that homelessness causes IPV, intimate partner violence. I'm not saying that being a veteran causes it. But what I'm saying is that we're noticing these things that are co-occurring at the same time. So it's not that they're just having to deal with, oh, I just went through this terrible situation with my partner, but there might also be, and I have a traumatic brain injury, and I have no place to live. So these are very complex cases of people, the situations. What are some risk factors in women veterans for intimate partner violence? So what we know from the literature is that definitely prior interpersonal trauma is a risk factor for future intimate partner violence. Military sexual trauma is a risk factor. And mental health disorders like PTSD, depression, and substance use disorders are risk factors for intimate partner violence. So I want to speak about these a little bit. So focusing on prior interpersonal trauma and military sexual trauma, a study of Navy recruits found that 30% of women reported experience of physical intimate partner violence, and 67% reported psychological intimate partner violence. So very high rates just going in, just being recruited into the Navy, which we can understand, trying to maybe get out of a bad situation, or build some stabilization for themselves, or some independence, or a sense of strength, and lots of good reasons. But these are very high rates walking in the door. A study of women veterans found that more than half reported pre-military physical or sexual violence. So again, that sort of fits this Navy recruit study. And women veterans with documented history of intimate partner violence are 2.5 times more likely than women veterans without this documented intimate partner violence to report military sexual trauma. So again, these things go hand in hand. So again, like I said, just because you have experienced intimate partner violence, that doesn't mean you're going to get PTSD, depression, substance use disorder. It's not a death sentence here or a stressful sentence, but certainly they're at risk. 31 to 84% of women with a history of intimate partner violence are diagnosed with PTSD. PTSD increases a woman's risk for subsequent intimate partner violence, so there's a recent study about that. That having PTSD in and of itself puts you at risk. And that 48% of women with intimate partner violence have diagnosed depression. So again, those women veterans with intimate partner violence have higher rates of PTSD and depression than women veterans with no history of intimate partner violence. So again, I'm not saying it's causing it, but I am saying it's certainly related. And that women veterans are at increased risk for misuse of alcohol versus non-veterans. Health impact of this. Women veterans with sexual and physical assault histories are more likely to report chronic health conditions, lower health-related quality of life for years after military service. So it's not something that people just sort of, it happens once and then they move past it, as much as we wish that were true. It certainly can affect their life for many years after. They report higher likelihoods of cardiac risk factors and digestive system disorders. In particular, psychological intimate partner violence in women veterans is associated with poor self-rated health. Physical intimate partner violence in women veterans is associated with chronic pain, smoking, problem drinking. And sexual intimate partner violence is associated with PTSD, other mental health diagnoses, and smoking. So this is a public health concern. I think, and this slide I want to say, I think this is a good sign. Women veterans with intimate partner violence have increased health care use. So if they are in the system, right, if they're in the VA system, they're using it. They have higher numbers of monthly health care encounters. They have more emergency room visits. 95% of them who are in the VA have sought mental health or social work treatment before. So in some cases, this is light, positive because they're getting care. They're advocating for themselves, which is a good sign. However, this is not looking at women vets outside of VA. So I'm sure there are a number of vets who have these experiences who are not in the system and who may not be getting the care they need. But once you're in, it looks at least you're making use of it. So I want to talk about clinical things to think about quickly before I wrap up here. I think I have a couple. So you have to think about this. This is a very complex issue, the experience of intimate partner violence, and multiple systems are involved. And so it's not something you just sort of throw them into a mental health clinic and be done with it. It's not something you say, oh, well, we screened and they said no, so that's that. Or it's not that, oh, well, we just need to get her a job and she'll be fine. This is we want to sort of do a 360-degree sort of view about, well, what do we do? If someone walks in and this is their experience, what do we do? One category of intervention is psychosocial. This is Sword's Ballywig. They're very good at this sort of domain. So I'm going to leave that to them to sort of, not leave that to them, but I'm not going to go into a lot of details about these interventions. But basically, obviously they need physical health treatment, they need legal advocacy, housing services, child care services, education, employment, safety planning, which I can go over if people have questions about that, Skills building, just basic skills building. What is intimate partner violence? Oh, I've been experiencing that. Oh, how do I keep myself safe? Those kinds of things. If after the experience of intimate partner violence, someone then does develop a mental health disorder, obviously I would recommend evidence-based treatment. So, and I'm going to spend some time talking about that in the next screen, so I'll skip that for now. And then overall, what I think is important is for us to be screening. So the U.S. Preventative Services Task Force and Institute of Medicine recommend screening for women in this age range. The VA currently has no such policy, no national policy that's screening. But this varies by facility. So some VAs are great at it, some are not. And I'm not familiar with every VA policy, every VA across the country, so I can't speak on that. But I can say that often providers, especially in primary care clinics, have limited training. So if you're screening in a primary care clinic versus in a mental health clinic, which is probably where you should be screening, but the providers may not know the right questions to ask or know how to document it or know how to follow up if someone does click the box or say, yes, this has happened to me. So I want to just talk a little bit about a possible scale to use that might be helpful as well for screening. Oops, what did I do? Okay, women, veterans, and trauma treatment. So quickly, this is from Judy Herman's work, who did a lot of work with women who had trauma experiences, and certainly intimate partner violence would be one of those experiences. And she recommends a phase-based model of treatment. So basically, the first phase would be establishing safety, which could include a lot of the psychosocial interventions that SWORDS does, for example, social work stuff. So, housing and a job and education and, those kinds of things, sobriety. That would be sort of phase one. Phase two, if they elect to go to phase two, is this remembering and mourning phase where you actually do trauma-focused treatment. And phase three is more sort of maintenance. Okay, now that I've made it through the, I've got a base and I've sort of processed what's happened to me, now I can sort of build my life in these value-laden directions. This slide talks about the different treatments available at VA. So I'm speaking again, I'm a federal health employee, so I'm a VA employee, and speaking about what the services offered at VA for women vets. Obviously private practitioners, community providers, they can do anything, they can have all kinds of options. But at least what's available in the VA, here are certain treatments and where they might hit those particular phases of treatment. And I'll talk more about them on the next slide. But the big checkboxes sort of indicate, yeah, this hits this really well. And the small checkboxes means, well, it sort of covers it, but it's not a major aim of the treatment. Specific evidence-based treatments that are being talked about right now, at least among VA staff for women vets with IPV experience or exposure. The first is cognitive processing therapy, which is if you see here, it's a phase 2 treatment, sort of mini phase 3. It's widely available in the VA. There is evidence that supports it, so there are studies that have found that it does treat PTSD and depression in women veterans with intimate partner violence. And there's a recent study that came out that says that it also helps reduce the risk for re-victimization. So women who go through cognitive processing, women vets who go through cognitive processing therapy are less likely to report re-victimization in the future. There are a couple other therapies here, cognitive trauma therapy for battered women, helping to overcome PTSD through empowerment, that are also evidence-based and also treat PTSD and other comorbid conditions like depression. That are being studied by VA staff and among women veterans. So that doesn't mean that they're widely available, but it means that they're being developed. and may be disseminated at some point. And those are specific for women vets with a history of intimate partner violence. Dialectical behavioral therapy is, let's go back, that's a phase 1 and a phase 3 treatment. So it's sort of a basic and introductory treatment, as is seeking safety, which I'll talk about after that. These are skills-based interventions, and there is a lot of evidence about this treatment that it treats women with chronic trauma-related disorders like PTSD, which may result from intimate partner violence. So again, not, this is the #1 thing or the only thing that can be used, but it's something to think about using because it has helped women vets with a history of PTSD or other trauma disorders. Seeking safety, I put on here too. It's also a skills-based intervention. But the thing that's unique about seeking safety is that it also covers substance use disorders. And so it recognizes that substance use and PTSD often go hand in hand. And as I mentioned in earlier slides, this is true for women vets with intimate partner violence. And so that they also have higher rates of PTSD and substance use disorders. So this might be a nice place to start with somebody as they're sort of getting stabilized. But again, depends on your clients. The last thing I want to cover is screening, and just sort of a tool that is easily accessible and one I would recommend using if you're a clinician or a provider. I think this is something, a primary care provider could do the screening and then help a vet get to a clinician if the screening came up positive. This has been recently piloted in women vets as well, I think in Boston, and it looked feasible and it looked reasonable. But it's just a basic questions. If you don't ask people, they won't tell you. And they may not tell you if you ask them, but at least you're giving it a shot. So this is why I would include this. That doesn't mean you should ask them every appointment to fill it out, but certainly it would be something you got to open the door so that they'll come in. So these are some questions about, has this happened to you? How frequently does this happen? Physically hurt you, insult or talk down to you, threaten you with harm, scream or curse at you. I would recommend that folks have some training before doing this, so I wouldn't sort of say that the clerk at the front desk should be giving this out necessarily. But someone who is sensitive and able to sort of figure out, oh, okay, now if they say yes, then what do I do? So anyway, this is just an example. Thanks for the opportunity to talk, and I'm available for questions as they occur.
Dr. Valdez, thank you so much for that presentation. We did have a number of questions, so if you have a few minutes, I'd like to raise some of those. And we also had a number of really good comments as well. So I think one of the first questions that we'd like to bring up deals with some of the numbers you were talking about with regard to screening of women veterans and the different populations and the different branches of service and how they're reporting. I think the question surrounds those numbers and what is the difference between Navy and Marine Corps numbers, as the Marine Corps does separate basic training numbers and the Navy does not. Does that question kind of make sense to you?
It does. I'm trying to find my sources here. This is in reference to the...
And again, if this is something you'd like to kind of review your detail and get back to, we can do that as well.
Let's do that. I have a list of resources here, and I'm trying to sort of frantically go through to find where that particular finding came from. But I will pull it up and get it to you, I promise.
Okay, that'd be great. And then we'll make sure that the attendees today can get the summary of that. Kind of that split and source of information. Thank you.
Mm-hmm.
I guess the next comment actually has to do with we have somebody as an attendee who's actually part of the military liaison at San Diego Family Justice Center. So their particular aspect and angles of their questions, as she states, my questions of the legal aspect are always surrounded by time limits and constraints of jurisdictional issues, such as if the event, and I guess we're speaking specifically of intimate partner violence, whether these events occur on base versus out in the general community. And her comment is that it creates a very tangled web to weave through as far as services that can be provided. I just wanted to share that with everybody. I'm sure that's something a lot of people experience. A comment came in, Melissa indicated that the VA has recently approved a national policy for IPV screening and programming, and implementation is currently underway. I spent the last couple of minutes up on the VA's website and was unable to find that link, but we will hunt that down, and if Melissa actually has a shortcut to it, we'd welcome that as well. But we'll make sure we include that.
That's really good news.
Yeah. Another question we had was that, I beg your pardon, that the oh, I'm sorry, this is another comment, my bad. They use the Jackie Campbell Danger Assessment as a tool to provide the legal team with a gauge of the level of danger that the client is in. Sylvia again feels that this is very helpful in tactics of getting service and obtaining restraining orders. And we had a comment here from Perry. It's good that veterans are seeking care. However, research shows nearly half, 44% of women who are murdered by their intimate partner have visited an emergency department within 2 years of the homicide. This he cites the source of American College of Emergency Physicians. So hopefully when the veterans show up in ERs, some sort of screening for IPV and DV is being done. Doctor, are you aware of any specific implementations in your travels with your internships and that nature?
Of the implementation of different screening? Is that the question?
At the ER, specifically when Perry's talking about when veterans show up in the ERs, there's some sort of IPV-DV screening being done, specifically relating to their veteran service and care.
You know, I haven't worked in the ER at any VA, so I can't speak specifically to what they do in each ER. And again, up until recently, thank you, Dr. Dichter, there hasn't been a national screening tool used as far as I know, but certainly it varies.
Excellent. Excellent. Thanks for that. And then Melissa came through with the data, the National Program Manager. I'm about to share this with everybody, so we'll make sure it gets in the log, so everybody will have the information on who to contact the VA for that IPV-DV policy that just came up. So hopefully that's available on everybody's screen right now. And I think last call for questions or comments, making sure that everybody's had a chance to direct any questions towards our two presenters today, Dr. Valdez and Star Lara. Well, that is, I think, wraps up the Q&A session. And we have one final comment from Ms. Perez, who says, thank you for all you do. So we appreciate everybody attending today. We'd like to thank our presenters, Starlin Lara and Courtney Valdez. We'd especially like to thank you, our participants. Please note that each of you will receive an email with a web link to evaluate this presentation, and your feedback is important to us and greatly appreciated. Before we end the webinar, we would like to remind the grantees that the next webinar will be on June 19th at 11 a.m. Pacific Time, and the topic is homelessness and housing for California women veterans. We'd also like to remind grantees that our second regional meeting will be held in Los Angeles, California on June 25th at the Holloman United Methodist Church. Again, thank you so much for all your time. This concludes our webinar. You may now disconnect.